Dr. Patty Matsuda is a double doctor. She has a PhD and she's a doctor of physical therapy. She's in the Department of Rehab Medicine and is an associate professor. She has a lot of expertise in fall prevention. She's a fantastic teacher. And I'm going to just let her take it away here rather than take up all her time with her introduction. So thank you for joining us today.
Thank you, Kate, and thank you so much for having me today. And hi to all of you. I know that I'm speaking and reaching maybe a 5-state region, and that's very exciting to me. And so I tried not to make this presentation Washington-centric for that very reason, and have provided tools at the end for you guys to look up wherever you are about your local statistics related to falls. So with this, you can see the title is The Good News About Fall Prevention, and looking at fall prevention specifically in primary care. So let's go ahead and get started. You will see that here are the objectives for today's very short session. And I have provided my contact information because I really love this topic. It's such a timely topic, as you probably in attendance well know. And so moving along here very quickly, think about what you already know about falls. What are the current statistics related to older adults? And I'll be touching on that in the next slide or two. But just in general, who falls more? Who do you think? Is it a person who is an older adult? Is it a person who's aging with a neurologic diagnosis? Or is it those who are middle-aged? So sort of think about that. I'm going to have Kate and Amy sort of watching in the chat. I can't do that, but there is a right answer to the three of them, and it may not be who you suspect. So this is a slide just to tell you a little bit about the prevalence of falls and the national statistics related to that. And you can see that this is a really, really vital and important topic, especially if you're in family medicine, primary care, or internal medicine, because you will be seeing people who are age 65 or better. And you can see in the United States, more than 25 to 30% of adults in that age range fall every year, and that increases to 1 in 2 over the age of 80. So those who are termed recurrent fallers fall 2 to 3 times more. They are more likely to fall again if they've already fallen once. You can see that the number of deaths in 2019 was 34,000. This is the leading cause of death in older adults. Emergency rooms have recorded a lot of fall-related visits, and 10 to 20% of falls cause very serious injuries, such as brain injury or hip fracture. And so I want you to keep that in mind as we progress through the next few slides. So this is one of the Sentinel papers as far as falls related to the Medicare population. You see that it was published in 2009, but this was really an unexplored territory at the time. You can see that they queried a lot of participants who were respondents to the MCBS, or Medicare Current Beneficiaries Survey. They estimated 3.7 million had a single fall to 3.1 million having recurrent falls, and 2.2 million people across the United States who responded to this survey had a medically injurious fall. Recurrent falls were more likely with the list that you see there. And you could probably think of people who you might see in the clinic that have presented to you this way. But the more interesting part of this is fallers, not surprisingly, had larger utilization costs in healthcare than those who do not report falls, but fewer than half of the beneficiaries who reported falling talked to their healthcare provider about their fall. This is why it's so critical for us to maybe broach that topic with our patients and asking about the fall. They may not want to report a fall for various reasons that you can think of. And one of the biggest ones is they want to remain independent and are fearful that if they report falling, that they may not be perceived as able to stay where they are. 60% of the respondents reported receiving fall prevention information from their healthcare provider. And this is something that we can all do better at, and I think the stats are going to bear that out. So I just want to quickly touch on the consequences of falls, both to society in general and the individual. So here are the consequences to the society. So medical cost for falls in the older adult in the US was $50 billion. This is why this topic is so important. The projection, because the baby boomers are aging in, and this is supposed to be the highest year for the baby boomers aging in, is for 2040 is 240 billion. And we need to consider both indirect and direct costs. So indirect costs would be loss of societal productivity, both for the person who fell and also their care partners or their caregivers in lost time and wages, things like that. Direct costs, of course, would be healthcare costs, medications, and just direct use of healthcare services. But how about the individual? What does that look like? And you can see that there's a cyclical sort of start here. So first, a person falls. Then they may become fearful of falling, and as their own fear of falling strategy, begin to restrict their activity. This leads to decreased strength, impairments in balance, and their walking ability. You can see the list on the left is very, very important to not only us, but really to our older adult patients. So what are some risk factors? Think of who you've seen in the clinic, or for some of you who are still in medical school, what you've seen maybe out in your rotations or in people that you just see out in our community. So these are risk factors in the individual. You'll remember that in that cyclical sort of graphic that I had, muscle weakness or decreased strength was one, having a gait or balance deficit, and then a history of falls, use of a walking device, any visual changes or deficits, arthritis, impairments in activities of daily living, so they're basic ADLs. If they have depression, cognitive impairment, or they are aged 80 years or better, are all risk factors for the individual. The ones that you see in red are modifiable risk factors. These are some things that we can target to help our patients with to help decrease their risk of falls. It is thought now that cognitive impairment and depression also are modifiable, but your age and unfortunately having a history of falls is something that you can't change. But a key risk factor for falls is impaired balance. And you'll see the penguin falling and slipping on ice. And it probably was similar to what was happening on the streets of Seattle just yesterday. But this is a major risk factors for falls in both geriatric and neurologic populations. And think about your patients who are aging with a neurologic diagnosis. Vestibular problems, which do happen in the older adult, can also impact balance because it's one of 3 systems that really contributes to a person's balance. So I just want to highlight here the current guidelines that are out there. So the American and British Geriatric guidelines, so you'll see AGS and BGS guidelines, and these were both sentinel papers, one of which was updated in 2011 and has stayed pretty true. The Center of Disease for Disease Control and Prevention have also issued guidelines, as well as the World Guidelines for Fall Prevention that did come out in 2022 in Age and Aging. So I'm going to go and highlight the updated clinical practice guideline for prevention in falls in older person that was put forth by the AGS and the BGS. So they recommended for fall risk assessment for all older adults who present with a fall or have gait and balance problems. And you can probably visualize who this might be walking into your office or sitting in your office. And also for those who maybe don't have obvious gait or balance issues, but there's self-reporting difficulties with their walking or their balance. This assessment would include a history of the fall circumstances. So how frequently are they falling? What maybe symptoms they are experiencing, where they're falling, and any injuries they might be incurring. The other is checking their feet and their footwear. And this is something that's come up and I've actually talked to older adults about because they have become very concerned about their footwear. And if you have foot pain, if you have footwear that does not fit well, or you can see the wear of the sole on their footwear, it gives you clues as to maybe what's happening when they walk. A lot of people also like to wear slip-ons that may not fit very well. And so that's something to also take into consideration. And then moving on from there, doing a functional assessment, asking them how they're doing with their basic activities of daily living. If they're using any equipment to help them, such as a bath bench, grab bars in the bathroom, how are they set up at home? Their own self-perception of their functional ability. Are they fearful of falling? Do they have concerns about falling when performing any particular activity? Do they feel that they can do certain things, or are they worried about doing certain activities that maybe they used to do and not even give it a second thought? Any environmental or home safety issues, and this might relate to both the patient and maybe their family member or their care partner who comes in with them. And when you find out about the circumstances surrounding the fall, you may hear a lot about what may need to happen or if they might need a home safety evaluation. And then having their vision checked at least annually, especially for those who are reporting cataracts, have macular degeneration, and those sorts of things. When you ask about falls, and I hope you all will because older adults don't like to volunteer this information, asking about the history and the context of the fall over the past 12 months. But keep in mind that this is just a guideline. Think about recall bias and memory issues. I honestly can't remember what I did 12 months ago. And so asking an older adult patient who even has the sharpest of memory might be hard. And so some people say 3 to 6 months might be a good window to look at. And then at least one question about their own perception of difficulty with balance or with walking. For patients who report falls or difficulty with their balance, watch them, see how they're walking, if they're using their assistive device properly, or maybe it's too low, too high, or maybe it's not even the right assistive device. And if only one fall is reported and no unsteadiness in gait or balance are seen, then maybe you don't need to refer for a screen or perform a screen on them. So as a physical therapist, these are some of the clinical practice guidelines for the management of falls that we have available to us. And I just put them here so you see that there are guidelines coming out and constantly being updated. For us, we will look at balance because remember, this is a key issue in falls. And patients may share with you that they have been starting to feel unstable. And that's something you might hear just in them talking with you about their medical history. Also, you'll know medications, you'll know which medications might have interactions that might lead to an increased fall risk. And then have you experienced a fall? What were the circumstances surrounding that fall? Where did it happen? What were you doing? Maybe they were what we call dual tasking, trying to do two things at once and they were distracted. Or the time of day. Is it at night when they're trying to go to the bathroom? Is it happening late in the day? This might give you an idea of the pattern that's happening. Any injuries, they may not come out and say anything, but it's good to know. And then the new question is, were you able to get up on your own? Most people are now asking to learn how to get up off the floor. This was something that we didn't really consider, especially as people left the hospital to go home, but they've seen their peers, especially if they're at a retirement home, fall, and they weren't able to get up, and they want to have that ability and know how they should go about doing that. And then the last question that I have highlighted in red is, have you had any near falls? If they've had a near fall, like just falling into the wall or leaning into the wall or plopping into the chair, this is a near fall and gives you an idea of if they have any balance issues or they might be starting to have them. And then, are you fearful of falling or concerned about falling? In research, this concerned about falling has been used as a proxy for fear because fear evokes a stronger response. And so we did query older adults, especially those aging with a neurologic diagnosis, and they said that fear and concerns are two different constructs, that they exist on a continuum. So asking about if they're fearful of falling is very separate from being just sort of concerned about falling, but it's not really going to cause them to restrict their activity, which is the next point that you see here. That can lead to decreased physical activity, and we know that physical activity is so important in this population and keeping them up and about. Assistive devices, are they using them? Are they even using them properly? Some of them now can just go to Target or Walgreens and pick up an assistive device or have gotten them on loan from a friend. So they might not even be fitting quite well, or they might be using them improperly. The other part of this is the more assistive devices that people have and use, i.e. switching back and forth between them, increases a person's fall risk. And so for PT or anybody performing an examination for balance or fall risk, these are some of the tests that you might see in the chart. Functional reach, a timed up and go, which I think many of you are very familiar with, where you go from a sitting to a standing position, you walk 10 feet, you turn around, and then you go back and you sit down. And in this case, you can use an assistive device to take this test. The Berg Balance Test is also a familiar one. It's also known as the Berg Balance Scale, and so you might see BBS in the chart. And then gait speed is one that's come forward as a good predictor for falls. And in the recent AGS paper that I'll touch on in a minute, they were also citing gait speed to be used as a possible indicator of fall risk. So the American Geriatrics Society issued a response to the World Fall Prevention Guidelines, and I did send this paper to Amy, and it's a really good paper because it has a table, and I love tables. And so it's a quick look at things. But what's recommended is an annual screening for people who are age 65 or better, and a multifactorial risk assessment, and tailored intervention should be implemented for community dwelling older adults who are identified at risk. The AGS looked at what the World Falls Prevention Guidelines outlined, and they looked at fall risk assessment, what should be performed, what they recommend, polypharmacy, looking at cardiovascular risk factors, including people who have cardiac history, looking at blood pressure with changes in position, looking for orthostatic blood pressure changes, and then auscultation. Exercise interventions comes forward, and there's a lot of research being done in Tai Chi in multiple populations, not just for the older adults. And then really looking at cognitive screens, because cognitive, as you remember on that risk factor list, cognition is a risk factor. And for the World Falls Guidelines, they really recommended looking at executive function in particular. So in summary, you can see this is fall prevention. And what I do want to emphasize to you is older adults hate the word, two words together, fall prevention. Fall is very negative in their world. And there's a paper that's out there that says falls is the new F word for older adults. And they're not kidding. And so when you query older adults, they don't want to go to some fall prevention program. They want really to go to something that's like build better balance, or they say more positivity. So these 4 icons that you see here are just reminders. To make your home safer, occupational therapists have a wealth of information about this. Getting your vision and hearing checked, so optometry and ophthalmology and audiology can really be helpful in this realm. And then reviewing medications annually with you as providers for your patients, and also pharmacists. And then stay active, and really encouraging them to stay active and safe, and exercise. And so physical therapists can help. And also we can direct people to community programs, because there are a lot out there and it's a lot easier. There are also a lot of programs that they can tune into online if they're fearful of, especially the winter months, getting infected or exposed to anything, or if they have problems with commuting or going someplace to attend a class. So in summary, it really takes a village. So what we need to do as providers is to observe and listen to our patients, their family members, and care partners, because we get a lot of cues from that. Communication is going to be the key. Asking questions, gaining knowledge, and then understanding about what's happening, because this is a topic that just sort of engenders fear for our older adult population. And then providing education and reassurance. Physicians, nursing, PAs, PTs, all of us are members of this healthcare team, and we need to collaborate together to work to ensure safety in mobility, because our patients really do want to stay mobile. They really want to be able to participate and do what they love and feel safe doing it, and to decrease risk of falls and hopefully prevent future falls. And so this may mean referrals to different team members or community-based programs in order to help that. So I would be happy to answer any questions you may have. And also I have some online resources for those of you who are looking in different states for your falls data. You can click onto this CDC website, and it gives it by state by just clicking on your state. So thank you so much for the invitation to speak, and on a topic that I am really passionate about.
But I'll go ahead and introduce our speaker.